Good afternoon. Good morning to those of you on the West Coast. I'd like to welcome you to the National Practitioner Data Bank webinar on reporting clinical privileges actions. My name is Dave Lowenstein. I'm the director of the Division of Practitioner Data Bank, which is the organization here with the Health Resources and Services Administration that oversees the NPDB.
And welcome, everyone. My name is Matt Wiley. I'm the branch chief of Policy and Disputes within the Division of Practitioner Data Bank. We're really excited to be kicking off today's webcast series, and we really appreciate your attendance today.
For those of you that are NAMS certified professionals, we're happy to announce that we can offer one continuing education credit for attending this webinar today. Please make sure you've entered in your email address so you can get credit. This is the first of a new series of webcasts that we're doing here at the NPDB. Following our education forum we held last spring, we wanted to figure out and listen to you about how to reach many of you and how to get in touch with more of you at once. This is how we came up with this idea for this webcast. They will feature subjects today like clinical privileges reporting, but we have other ones planned on topics such as querying the NPDB and our attestation effort. We hope they provide useful information that will provide helpful as you interact with the NPDB on a daily basis. So today we're going to talk about the reporting of clinical privileges actions. Today we're going to cover some of the basic topics related to clinical privileges actions, as well as some of the more complex ones. Things such as investigations, proctoring, where you can find resources that will help you in deciding whether or not something should be reported to the NPDB. For those of you that are new to the NPDB, I wanted to give you a very brief introduction so we can quickly get into the material and into your questions. But in short, the NPDB is a web-based tool that houses information containing reports on clinical privileges, actions, other types of adverse actions such as licensure actions, as well as medical malpractice payments. Registered entities such as hospitals, health plans, and state licensing boards give us that information through those reports and in turn can query us where we provide the information back out. Our mission here at the NPDB is to improve healthcare quality, to protect the public, and to help reduce healthcare fraud and abuse throughout the country. Over the last 2 or 3 years, we've been spending a lot of time on our attestation efforts. So part of today's webcast, we will talk a little bit about that as well. And just to give you some context, currently the NPDB, I'm proud to update, has over 1.5 million reports on practitioners, providers, and suppliers throughout the country. These date all the way back to 1990. So not all of those practitioners, not all of those reports are on currently practicing practitioners. But I want to give you an idea of the breadth of information and the depth of information that we have.
Great. Thanks, Dave, for the nice introduction and for kicking off today's webcast. So what can you expect over the next 55 minutes or so? In just a few minutes, I'll be joined by one of my colleagues, and she and I will provide you all with a short overview session on clinical privileges reporting to the NPDB. After that session, I will come back and I'll give you a short, brief update on our attestation effort. And then after that, we will move towards the main reason for providing this webcast is to get to your questions. And together, Dave and I will answer as many of those questions as possible. We do want to thank those of you that were able to provide questions prior to today's webcast. Additionally, those of you who have been submitting questions while we've been speaking. Just as a reminder, if you do have a question that you want asked, you can do so by clicking on the Submit a Question link, which is on the webcast screen itself. So, with that, I would like to introduce one of my colleagues, Sherry Vorabanda. She's an analyst with me in the Policy and Disputes branch. And together, Sherry and I will be presenting to you on clinical privileges reporting to the National Practitioner Data Bank. In this session, we'll be discussing the reporting requirements for submitting clinical privileges reports to the National Practitioner Data Bank. We'll begin by reviewing the language in both the laws and the regulations. But we'll spend most of our time talking about specific scenarios involving issues that tend to be hot topics in the field. Finally, we'll discuss resources that can be helpful to you in answering all your questions about this topic.
To understand clinical privileges reporting, it is helpful to understand the law behind this reporting requirement. Essentially, the law speaks to two specific requirements when it comes to this type of reporting. Part A, the first requirement, states that any professional review action adversely affecting privileges for more than 30 days is reportable. If you take a professional review action that adversely affects clinical privileges for more than 30 days, then you must submit a report to the NPDB. Part B, the second requirement, concerns surrendering clinical privileges while under investigation. Accepting the surrender of privileges or any restriction of the privileges by a practitioner while a physician is under investigation for potential incompetence or improper conduct requires a report to the NPDB. Likewise, accepting the surrender of privileges or the restriction of privileges by a practitioner in return for not conducting investigation is reportable. While the requirement that self-restriction of privileges by a practitioner is not specifically mentioned in the law, it is noted that the rules and regulations governing clinical privileges requires this reporting. Now I want to go over the definition of two terminologies I just mentioned when I explained the law. The first terminology is professional review action. Professional review action is an action or recommendation taken during a professional review activity. A professional review action is based on competence or conduct of a physician, and it adversely affects privileges. You just heard me use the terminology a professional review activity. What does this mean? A professional review activity is an activity of a healthcare entity with respect to a healthcare practitioner to determine whether the healthcare practitioner may have privileges, to determine the scope or conditions of the privileges, or to change or modify the privileges. A second terminology I used when I explained the law was adversely affecting. Adversely affecting simply means reducing, restricting, suspending, revoking, denying, or failing to renew privileges.
So, to reiterate, the law stipulates that adverse clinical privileges actions lasting longer than 30 days are reportable to the NPDB. Now, this is a must for physicians and dentists, and a may for all other licensed practitioners, although the NPDB highly encourages the practice of submitting reports on other licensed practitioners. Additionally, the law stipulates that surrendering privileges while under investigation is also reportable, and we'll get into that topic next. Let's discuss the topic of surrendering clinical privileges while under investigation. First and foremost, investigations by themselves are not reportable to the NPDB. It is when you have the surrender of clinical privileges or the denial of clinical privileges while there's an ongoing investigation or in order to avoid such an investigation is when it becomes reportable to the NPDB. The NPDB broadly defines the term investigations. While it may look at a healthcare entity's bylaws for assistance to determine whether or not an investigation has begun or is ongoing, the NPDB retains ultimate authority in determining whether or not an investigation exists. In general, investigations must be the focus of a particular practitioner. So we're not talking about routine or administrative reviews that are applicable to all clinicians, but rather we're talking about scenarios where there's a focused review of a particular practitioner related to potential issues related to their professional competency or conduct. Investigations are also the precursor to professional review actions. And lastly, investigations are considered ongoing until a decision-making body takes its final action. So for example, let's say you have a scenario where a practitioner is under review, and the decision-making body has come to the determination they're going to offer the practitioner one of two paths. On one hand, they're going to offer the practitioner that they must submit to evaluation or monitoring. And additionally, they must complete continuing education credits. On the other hand, if the practitioner does not agree to such terms, they're going to have their clinical privileges suspended. Now, in this hypothetical scenario, the investigation would be considered ongoing, and that is because the decision-making body has not taken its final action. Non-renewals can also be considered surrendering privileges while under investigation. When you have a case where a clinician fails to renew their privileges while they are under investigation, a report must be submitted to the NPDB. In doing so, you're not simply reporting the fact that there was an investigation. You're reporting the fact that a clinician is failing to renew their privileges during a time in which they are undergoing investigation. It is important to note that practitioners do not need to be aware that there's an ongoing investigation in order for the report to be submitted. By the same token, when a practitioner withdraws their application for the renewal of clinical privileges while under investigation, a report must also be submitted to the NPDB. And in doing so, you're not simply reporting that there was an investigation, you're reporting the fact that a practitioner is withdrawing their application for the renewal of privileges while they are undergoing investigation. This is also true that it's reportable regardless of whether or not the practitioner was aware of the ongoing investigation at the time of withdrawal. It is important to note that if you have a case where a practitioner is withdrawing their initial application for clinical privileges, a report is not required to be submitted to the NPDB. And this is true regardless of whether or not there was an ongoing investigation at the time the clinician withdrew their application for the initial privileges.
Thanks, Matt, for covering the reporting requirements concerning privileges that are surrendered while under investigation. Let's move on to reporting requirements concerning adverse actions lasting longer than 30 days. As you recall, when we reviewed the reporting requirements under the law, there was a Part A and a Part B to the requirements. Matt just talked in depth about Part B. So now we're going to switch gears and talk about what's reportable under Part A. An example of an action that might last longer than 30 days is a summary suspension. If a summary suspension is in effect for more than 30 days, based on professional competence or conduct and the result of a professional review action, then it is reportable. If a summary suspension imposed for an indefinite length has not lasted more than 30 days but is expected to last more than 30 days, the suspension can be reported. If later the suspension does not end up lasting more than 30 days, then you void the report. Denials and restrictions are other examples of action that might last more than 30 days. Denials and restrictions greater than 30 days and resulting from professional review relating to professional competence or conduct are reportable. Restrictions that prevent practitioners from exercising independent judgment are reportable. And denials of initial application for privileges are reportable. Proctoring is another area where a report may be required. A physician or dentist who cannot perform certain procedures without proctor approval or presence is considered to hold restricted privileges. The inability to practice the full scope of privileges without a proctor's presence or approval is a restriction. Once the physician or dentist is prohibited from performing a procedure without a proctor, his or her privileges are adversely affected. The number of cases required to be proctored at the time proctoring is imposed, or the expectation that the restriction be concluded in fewer than 31 days, is irrelevant for reporting purposes. Remember, the reportability of an action, such as proctoring, hinges on whether the restriction is in effect for more than 30 days.
So now we want to make you aware of several resources that can be helpful to you on this topic. Here, you have an example of an infographic that we have on our website. It's located at www.npdb.hrsa.gov. In addition to the infographic, we have many other helpful resources, including FAQs, on this topic and many others. We want you to be aware that you can call our customer service center with questions on this topic or any other topics related to the National Practitioner Data Bank. The customer service center can be reached by dialing 1-800-767-6732. Thank you very much for watching today's session.
Thank you for tuning in.
Great, and so a big thanks again to Sherry for assisting me with co-presenting on clinical privileges reporting. Hopefully you all found that informative, but I know that there's several other questions that you all have, and we want to get to those as soon as possible. Before I talk about attestation, I do want to make you all aware that the slides that were presented today are available on the webcast screen for download. So a lot of the information, a lot of the definitions and language that we will be using in answering a lot of these questions are found in those slides. So we want to make sure that you were aware that you can download those. So before we get into the Q&A portion, just wanted to spend a few minutes providing you all with an overview and update of our attestation initiative. So first off, what is attestation? Simply put, it's our education and outreach effort in which we're ensuring that eligible organizations are meeting their NPDB reporting requirements. So what happens is during the attestation process, organizations will attest to the fact that they are indeed reporting all reportable actions and or medical malpractice payment reports to the NPDB per federal regulations. Now, we've been working very closely with state licensing boards for several years. And what we did was, starting in 2017, we rolled out the attestation initiative intermittently with various organizations, various stakeholder organizations. So beginning with health centers in 2017, we began the attestation initiative. We then subsequently followed up with other organizations such as hospitals, health plans, medical malpractice payers, and most recently, we rolled it out with all other eligible healthcare entities. So, essentially, as of today, if you are registered with the NPDB, you are going to be asked to attest to your reporting requirements. Now, many of you are well aware of the NPDB and the registration process. Every 2 years, you're asked to renew your registration. And what we've done with attestation is we've tried to make it as easy as possible, and we've tied it to registration renewal process. So what happens is once you complete your registration renewal, you'll be then taken into the attestation workflow, where you can then attest to whether or not you are indeed reporting all required reports to the NPDB. Okay, so thank you for indulging me for a few minutes as I gave you an overview and update of the attestation effort, and a big thank you to all of you that have participated in this effort. And now I'll pass it back to Dave, who will tee up the Q&A session of today's webcast.
Great, thanks, Matt. We wanted to save a lot of time, really. We knew most of you probably wanted to ask questions and hear what our answers were. So as we're starting that, I wanted to let you know a few things. One is we really, really appreciate those of you that have already submitted questions to us. We'll get started on those in a minute. As with any time anybody asks us a question about whether or not something is reportable, we're going to do our best to give general guidance that applies to the situation, but it is important to keep in mind that every situation is different, and sometimes when we get 2 or 3 sentences of facts that might leave out other facts, that those facts that were left out could change the answer. So again, we're going to do our best to give general guidance and be as specific as we can, but to please remember that any time you have a question for us, that sometimes we need to look at a lot more than a 2 or 3 sentence description. For those questions we're not able to get to today, we know we have well over 1,000 people on the webcast today, and we've been getting lots of questions. So for those we're not able to answer, we're going to do our best to answer those in other forums, such as our Insights, which is our monthly newsletter, and we may get back to individuals on some of the questions, but we'll do our best to bake the answers to those questions in our future presentations and materials. So with that, we're ready to get started with our first question, and there still is time. Please make sure you click on that Submit a Question button if you have a question for us.
Okay, thank you. We've received a few questions regarding what to report during an investigation. Is it reportable if a practitioner agrees not to exercise their privileges during an investigation, but they don't actually surrender their privileges or resign?
Yeah, so good question, Dave. I'll take a stab at this one. Yes, agreements not to exercise privileges are typically reportable if a clinician is under investigation. So the language in the regulation states that any acceptance of the surrender of clinical privileges or any restriction of such privileges while a practitioner is under investigation or in lieu of performing such an investigation, it would be a reportable event. So the specific question was agreement not to practice. That would be considered a restriction or resignation while under investigation.
Okay, thank you, Matt. What if a physician doesn't know they are being investigated and they resign? Is their resignation during an investigation reportable?
I can take this one. Yes. It doesn't matter if the practitioner, the physician in this instance, is aware that an investigation is ongoing in order for it to be reportable. One thing that is important, that the organization that is undergoing that investigation or conducting that investigation should have some kind of evidence should that report later be disputed. If the physician says, there was not an investigation going on, we would go back and double check your evidence that you had conducted or began conducting or plan to begin an investigation. But the fact that the practitioner is unaware of it does not matter in terms of reportability. It would still be reportable.
Right.
Okay, thank you. What about taking a leave of absence during an investigation? Is that reportable?
Yeah, so I'll jump in and take a stab. So, and we've gotten this question a lot. Leaves of absences can be considered a restriction while under investigation, as long as all the reportability requirements are in place. So again, with respect to leave of absence, it really depends on whether or not, to the extent to which the clinical privileges are intact or not. So a different way to put it is if a physician can take a leave of absence and during that time their clinical privileges are fully intact, unencumbered, then it wouldn't be reportable. However, to the extent that the leave of absence restricts their privileges and there was an ongoing investigation, it becomes reportable.
Thank you. Can you describe the types of behavioral issues that must be reported to the NPDB?
Sure, I get this question a lot. And the first thing, anytime I hear a question like this, or what kind of issues or what kind of incidents need to be reported, it's important to keep in mind that as the NPDB, we do not collect reports specifically on incidents or issues that occur. What really must be reported is the action that took place, the action that was taken as a result of that one or many issues or incidents. So I kind of would flip that question back around. Rather than saying what types of behavioral issues should be reported to us, what I would say is that any action taken by, any professional review action taken by that medical staff or what have you, where the restriction, again, you kind of hit those marks. It needs to be a professional review action. It needs to last longer than 30 days, and it needs to be related to the professional competence or professional conduct of that particular practitioner. That's what makes it reportable. So I don't like getting into examples of what did the physician do or didn't do, but if that review body took a professional review action against that physician, and it was because of, in this case, sounds like potentially professional conduct issues, then yes, that would be reportable once it lasts longer than 30 days. Right,
and just to tag on to that, as Dave said, hitting all the marks. oftentimes what we do is refer back to the language in the regulations. And so, as Dave clearly laid out, those are the specific points in the regulations, and we're always going to defer to that.
Can you clarify, when you say 30 days, do you mean calendar days or work days?
Calendar days. Yeah. More than 30 calendar days. So it's basically day 31, right, calendar days.
Thank you. If a new physician comes on and has no experience with a procedure and then has to complete training for a certain number of cases with another physician who has experience with that procedure, before they are granted independent practice for that procedure, is that reportable?
So I'll jump onto this one. So this is going to be one of those where it's going to depend. Where if this is a routine practice for all practitioners in order to receive this level of privileges, then it would fall under not being reportable, right? So if it's a routine thing that allows them to acquire that particular clinical privilege, it would not be reportable. It's when there is the adversely affecting their clinical privileges. So the definition of that includes restriction, reduction, revocation of such privileges. And what it sounds like in this case is that the physician did not have the privileges to begin with, so it would not be reportable. I don't know if you have anything
to add. You hit on my favorite phrase with NPDB reportability, which is it depends. And really a lot of time it does is are you restricting, is that something you're doing because of a particular competence issue with that particular physician, or is this just a routine practice that all practitioners, like Matt said, would go through in order to get that level of privilege? Right.
Great, thank you. My next question relates to proctoring. After conducting a professional review of a surgeon's competence, the hospital assigns a surgical proctor. Is the hospital required to report this action to the NPDB?
It depends. No, it's my favorite answer, and that's usually right. So with the case of proctors, it's a very similar situation. So you led the question with there was following a professional review activity. So we kind of check that box. Mm-hmm. The next question we have to look at is in your world, is that proctoring a restriction of privilege or not? And different people use similar terms or the same term to mean different things, so I'm going to try to explain it using different terms. We hear proctoring, monitoring, assisting, all kinds of different verbiage, but what we're really getting at is, can that provider exercise his or her full scope of privilege or not? So if proctoring in your world means that, let's say you're a surgeon and you're going in to do the surgery and that proctor does not show up, are you allowed to go forward or not? If you are, if that provider practitioner is allowed to go forward, we would not consider that a restriction. However, if they cannot proceed without the permission of that proctor because the proctor is not there, they cannot go forward, then that would be a restriction. Mm-hmm. So once that would reach past the 30-day threshold, then that would be reportable to us. And I kind of use that as a example on the other side. So sometimes we've heard of proctoring or monitoring in a slightly different explanation, which is that the door, let's say that the door to the surgery room basically had to be open for that monitor or that proctor to come in. But if they didn't come in, the procedure could proceed as planned. That we would not consider a restriction. So really, again, you're kind of looking at those same elements. Was there a professional review action here? We said yes. Did it last longer than 30 days? And at this point, I forget the question, but I think so. And then, was it a restriction of that privilege? Did it adversely affect those privileges? So that's really the focus in this case of was that a restriction or not that would make it reportable or not.
Right. And I think you nicely outlined the answer, and I have nothing to add other than I think between Dave's answer and Sherry did a nice job of covering proctoring as well. So be mindful that if you have future questions about proctoring, that those are on the slides as well.
Yeah, and that is an area we did expand upon in the October 2018 version of the NPDB guidebook, and so I did my best to stick to that as best as possible.
Great. We have a similar question. We have a practitioner who was engaged in a quality improvement plan, and they resigned while in the quality improvement plan. Would this be considered a resignation while under investigation?
I'll jump in.
Sure.
So, like Dave said, these are sometimes always kind of difficult to address. It depends on the situation, but I think if I remember correctly, so first of all, quality improvement plan in and of itself could potentially raise two issues with reportability. So, in and of itself, if a quality improvement plan restricts the privileges of a practitioner, and it lasts longer than 30 days, and it's a result of a professional review action, then that itself might be reportable. Now, I think the question got into resignation during the quality improvement plan, and that's the second part that the issue brings up is, does the quality improvement plan itself meet definition of investigation? And so, again, that goes back to, we have a lot of great helpful resources on our website and our guidebook that outline investigations. But simply put, and as I presented earlier, investigations must be focused on a specific practitioner related to his or her potential issues with his or her professional competence or conduct issues. And that's going to be determined at the entity level. Now, if it does meet that definition of investigation and there's any surrender of privileges or any resignation or any restriction of such privileges during that, and it's deemed to be an investigation, then yes, it would be reportable to the NPDB.
Okay, thank you. We have a question now about disputing reports. If a practitioner is reported to the NPDB, can they dispute the report?
I will gladly take this question. And Dave looked over at me. So, like I said, I'm the branch chief of policy and disputes. And yes, absolutely. There's several steps with this process. So, if you are the subject of a report in the NPDB, you receive notification. You are allowed to access the information that was in the report, and you can do several steps. Step number one is if you flat out dispute the report, you can make that known within the system. We give you information to log in and look at the information in the report. You can then select an option that says, I dispute this report. Now, what does that do is it shows up on the report itself. So any queriers submitting a query on a particular doctor, they'll see on the report that they've disputed that. So that's one step. Another thing that a practitioner can do is they can add a subject statement, and this is a open-ended text field. It's capped at 4,000 characters, where the practitioner can go in and add their side of the story. So if they want to come in and say, here's my side of the story, here's why the report was submitted or why I disagree with it, that's available to the practitioners as well. And that information is also conveyed with the report itself. So if someone queries and you have a subject statement in there, the receiver of the query will have that information available. Now, the third option is what's known as dispute resolution, and that is an administrative review process that has been delegated down to the division level that allows us to do a review of reports. And so what that does is allow clinicians to submit information on why they dispute the report and accompanying information along with that. We will then collect information from the reporting entity and do the administrative review to determine one of two things. So our delegated authority allows us to do one of two things during this review. We're allowed to, A, determine if it was deemed to be reportable per regulations, and the second part is if it's accurate as submitted. So does the report reflect the record? So hopefully that answers that question. I kind of went through all the different steps that are allowed for practitioners. And all that information, again, is very clearly outlined in not only our guidebook and our website, but we just recently deployed a really great infographic that helps subjects of reports understand, okay, I'm the subject of an NPDB report, now what? What avenues are available to me? So that's available on our website, so check that out.
One of the things Matt brought up there is that is the accuracy and the accurate according to the record of the entity. And one thing we always want to make sure to point out that we are not in a position to overrule or overturn the decision of an entity, whether it be a hospital taking a clinical privileges action or a state licensing board taking a state licensure action, that we do not substitute our judgment for that entity. We don't say, oh, you suspended this provider, but you really shouldn't have done that. That's not what the dispute resolution process is about. It's about ensuring that the action was taken, as Matt said, is reportable, and then it's accurately reflected in the official record of whatever the process was.
Great, thank you for adding on to that. Yeah.
Okay. If a physician is suspended for incomplete or delinquent records and has been suspended for 30 days or longer, is that reportable?
So it would need to be 31 days or longer, just to clarify there. If it was only for 30 days, it actually would not be reportable. But then, so kind of just taking it into two separate pieces. So it would need to be 31 days or longer. But the second piece of that is inaccurate record keeping. And so really that often comes down to was that related? So the question really here is, was it related to clinical competence or conduct, right. And is it a professional review action? Right. So assuming it's a professional review action, really looking at that, was it related to professional competence or conduct? So inaccurate records or records not being completed in a medical file, me as a person, I want to make sure that my medical records are accurate. I would say probably, but again, this is one of those things might come down to the bylaws of the particular organization, how they define professional review action, how they define conduct issues versus clinical competence issues. But I can tell you we do have many reports in the NPDB related to record keeping, accurate notes, accurate charts, and those that have been disputed and the organization's been able to explain and to make that connection between records and quality health care. That's really not a big jump in my opinion.
Right.
If a practitioner is suspended indefinitely, do we have to wait for more than 30 days to pass, or can we report the practitioner immediately?
So I'll jump in for this one. So summary suspensions, no. If there's a summary suspension in place or invoked, and it's expected to last more than 30 days, it can be reported. If down the road it's lifted prior to 30 days occurring, then the report could be voided. So the one thing that I do want to point out with summary suspensions that's a little bit different from reporting other clinical privileges actions is that the action is taken prior to the due process, right? So with normal clinical privileges actions, professional review actions, there's the due process, and then the action comes as a result of that. With summary suspensions, those can happen prior to that process playing out. And if it's indefinite, it can be reported, and then if it lasts longer than 30 days, 31 plus days, then it remains a reportable event to the NPDB. If, however, you submit a summary suspension for an indefinite period of time, and like I said, if that summary suspension is lifted prior to 30 days, you can, as an organization, go in and void that report.
Yeah, I would just add two things on there. We're talking about voids a little bit, and I don't know how familiar everybody is with a void report, but when a report is voided, it basically becomes as if it never existed. Yep. So following a void, if that was the only report a particular practitioner had, once that void comes in and a query were to come in on that individual, we would say we have no reports on that particular practitioner. And with a void, we also notify any organization that we provided that report to through a query within the last 3 years. Mm-hmm. We tell them that report is no longer valid and all copies of it should be destroyed. So that's one point I wanted to make there. The other point is that when we talk about the question was phrased, I believe, as can we report it? And as Matt said, yes, absolutely. And that's actually something we'd encourage. If something has happened and it's rising to the level of you're taking an immediate, indefinite action to suspend somebody's clinical privileges, we know you don't do that often, nor do you do that lightly. And so whatever the cause of that was, we're guessing there's probably a public health and safety reason for that, of you want to make sure that those privileges are not being exercised. But providing that information to us allows that to then provide that back out to others as well. And so really, if you think of it from a public safety perspective, that anyone that has that practitioner enrolled in continuous query, maybe another hospital up the road or across town, or frankly in another state nowadays, where that practitioner has privileges, any state licensing boards, health plans, etc., that's probably something others want to know and should know, so we would encourage you to report those as soon as possible.
Great, yeah, and thanks, Dave. Those are great points, and I'm glad you picked up on. Oftentimes when we present, we fall victim of our own jargon, so I'm glad that you picked up on that.
That's fine.
Yeah.
Okay, we have another question regarding summary suspensions. What happens when a hospital summarily suspends a physician's clinical privileges to allow time for allegations to be investigated? And the day after the summary suspension was imposed, the physician requested an educational leave of absence. If the hospital grants the leave of absence, does a summary suspension need to be reported?
Can you repeat the last part of that question again? If the hospital grants the leave of absence, does the summary suspension need to be reported? Well, this raises kind of a few issues here. One is you have a suspension, and it hasn't yet lasted 30 days, but if that suspension is still in effect at day 31, that suspension in and of itself becomes reportable, right, regardless of whether there was a request for a leave of absence, whether or not it was granted. So really that in and of itself doesn't matter. Mm-hmm. The other thing I heard in the question was that the reason for the summary suspension was to look into something, to investigate, if you will, something. So it sounds like to me that that there's an investigation underway. So the fact that somebody is taking a leave of absence while under investigation or concurrent with an investigation, that also starts to sound like accepting the restriction of privilege while under investigation, which frankly would become immediately reportable. So you have a few different things going on there, several of which probably could be reportable. It's just a matter of kind of how you're looking at it and the order of things that happen. But one thing to remember is, doesn't matter, leave of absence, anything. If there's a summary suspension on the books, that must be reported once that last 31 days, regardless of what happened to the practitioner, requested leave, not working, unless that suspension is lifted before we hit day 31.
Right.
Okay. We have another question about privileging actions. If our hospital took an adverse privileging action a few years ago and it meets the NPDB reporting requirements, but has not been reported to the NPDB, are we still required to report it?
Yes. So there's no, for lack of a better term, statutes of limitations with reporting. So we accept, although we encourage reporting as soon as possible, within 30 days, that if there's been a finding where there should have been a reportable event and it happened in the past, yes, we still require the report to be submitted to the NPDB.
And frankly, we hope that this attestation effort has encouraged some of you to go back through your notes and through your files and look to see if there was anything missing, because frankly that is one of the goals of the attestation effort, is to look and make sure that somebody there in the organization with some authority and knowledge of the types of activities taking place will really look introspectively and see if something should be reported. I will also bring up that I know several times, at least since I've been involved in the NPDB, that dispute cases involve a report that was not submitted within 30 days. And one of the reasons that the practitioner is disputing the report is saying, the entity had to submit it within 30 days, but they didn't, so I want the report removed. And Matt, as Policy and Disputes Branch Chief, will tell you that is not a reason for an NPDB report to be voided or removed. We want and require that they be reported within 30 days, but we also understand that sometimes things happen, something might get missed, and it is far more important to get that into us rather than not.
Yep. Right.
Thank you. One of our attendees asked the following. Our Medical Executive Committee recommended that a physician not be reappointed, but the physician's current 2-year appointment ends before a hearing can be held or a final action can be taken by our governing body. Is this reportable?
Could you repeat the question, please?
Sure. Our MEC recommended a physician not be reappointed. The physician's current 2-year appointment ends before a hearing can be held or a final action can be taken by our governing body. Is this reportable?
Yes, it is. And the reason for that is that as the reappointment is going on, that and I say yes, probably. It sounds like the recommendation from the Medical Executive Committee is because of a particular issue that happened, might be looking more into that. And we simply can't allow a delay or time expiring to say, oh, it's not going to be reportable because they no longer are privileged here. So when we have an investigation, really just the mere non-renewal of clinical privilege when you'd be otherwise eligible to renew, that in and of itself becomes a reportable event.
Right. That's what I was going to say, was non-renewals while under investigation are indeed reportable to the NPDB. And it sounds like at the beginning of this, there was the initiation of an investigation. Again, sounds like there was that focused review on a particular practitioner. And again, is it based on their potential issues with their professional competence or conduct? And if so, investigation and the non-renewal would be reportable.
Thank you. Are you required to report when a nurse practitioner or physician assistant resigns under investigation to avoid an action being taken?
Not. So in the language and the regulations are very specific that who must be reported are physicians and dentists. And to go back to my earlier presentation, other healthcare practitioners may be reported for similar actions. And it's the NPDB's stance that we highly encourage the practice of submitting those reports on other than physicians and dentists.
Again, this is another public health issue for us, and And the must for physicians and dentists and may for others, that really dates back all the way to the Healthcare Quality Improvement Act of 1986, which was the original NPDB statute. So that is something that was very clearly spelled out in there. I get this question all the time. A couple times people have shaken their finger at me and say, "Why don't you change this?" And I show them where it is, and that's the legislation that was written by Congress in 1986, and we don't have the authority to change that.
If a hospital terminates a physician's contract for clinical issues, is that reportable to the NPDB?
If the contract termination, it could be reportable under clinical privileges action, so long as the reportability requirements are met. Again, going back to the points, is if there was potential issues with their professional competence or conduct, there was a professional review action, and then the contract termination occurred, it could be reportable under clinical privileges. The other part of this is contract terminations in and of themselves are not particularly reportable under the regulation for reporting clinical privileges, but it may be reportable under a different part of our regulations for other adjudicated actions. So for those taking notes at home, the specific subsection for clinical privileges is 60.12 in our regulations, and the other one that I alluded to, other adjudicated actions, is 60.16.
Right. And that 60.16 mostly, in the case we're talking about kind of a termination, would relate mostly to either contract terminations with health plans or some kind of action taken on a federal government employee, for example. It's always one thing we try to remind folks is that not everybody's rules are always the same in every situation. But as Matt said, it really depends on if we're talking just clinical privileges, really depends on whether that contract termination is a professional review action, whether there was peer review involved or whether it was simply an HR decision. Right.
Okay, our last question for today relates to health systems with more than one facility. When a practitioner is associated with a health system with several associated entities, who is responsible for reporting an action to the NPDB?
It depends. Yeah, and so really it boils down to how you're structured. So if your entity is a unified entity and shares a medical staff and all the decision-making, the discipline and everything is done centrally. If there's an adverse clinical privileges action, that would need to be reported to us once. However, if your organization is set up and that is decentralized into multiple pieces, or each hospital has their own medical staff, then really what it boils down to is how many of those decision-making bodies took an action. Right. If you have a health system with 10 different medical staffs and 10 different decision-making authorities, then that physician, how many of them took that action? Did all 10? Did 1? Did 3? And so whoever took the action, whatever body took the action or actions, would then be required to report.
Right. And always trying to plug our resources. There's a really helpful infographic on our website, not specifically on reporting, but similar to this situation, this question that you raised. It outlines how many queries do I need to run, and it gets to the same heart of this question of whether or not there's a centralized or decentralized organization structure.
Yeah. So this time really kind of went fast in the Q&A, and we get that. And so I wanted to, again, thank you for submitting those questions and giving us the opportunity to answer them. I'm sure our answers may have generated some more follow-up questions. So anything we didn't get to or that there's follow-up, you can feel free to always to send those in to us, and we will do our best to answer them. through future webcasts like this or through our insights, or again, maybe a specific direct message back to you. I mentioned Insights. That's our monthly newsletter, web newsletter that we send out and post on our website. If you're not registered to receive Insights, that's something you can very easily do right on our website. And I believe there's a link to our website and other resources up for you right now in the webcast, on the webcast screen. Some other tools that are there, Matt mentioned that the slides that he and Sherry went over, those should be available for you, as well as links to our guidebook, or specifically the clinical privileging, reporting clinical privileging actions chapter. Guidebook has a lot of other information about querying, about state licensure reports, medical malpractice, what have you. We also mentioned one of the infographics, or maybe a couple of the infographics. We have one, just the purple one, specifically about reporting clinical privileges actions. We also, as Matt mentioned, just put out a new one on the dispute resolution process. But there's a wealth of information available out on our website. We will announce the future webcasts on our website as well as and through Insights, but I can say we're happy to announce that we've scheduled the next one. We're going to be doing these every few months. Our next NPDB webcast will be on February 20th, 2020, 2/20/2020 at 2 p.m. Eastern. Right. Maybe, well, we thought about starting at 2:20, but thought that might be a little confusing for everyone, myself included. And the topic of that one will be querying. Our website, at some point, and hopefully the not-too-distant future, will also post a video of this webcast for anyone that wasn't able to attend or if you just want to watch it again. So again, with that, we really appreciate your time and giving us your questions and time, and we look forward to seeing you again soon. Yes, and thank you all very much. One final plug. If you haven't done so already, please submit the satisfaction survey. We really want to hear from you all. This was a generation from the Education Forum, so that continuous feedback loop is always helpful in making sure that we're getting you all the correct information. So thank you for your participation today.